Rheumatoid arthritis, RA, can be challenging to diagnose due to its potential to mimic several other conditions. Some of the most common mimics of RA include 1. Osteoarthritis. Often mistaken for RA due to joint pain and stiffness, but osteoarthritis typically affects larger, weight bearing joints and lacks the same systemic inflammatory features. 2. Psoriatic arthritis, SA, can involve small joints similar to RA, but often features skin and nail changes like psoriasis and dactylitis, sausage fingers, toes. 3. Systemic lupus erythematosus, SLE, can cause joint pain and swelling similar to RA, but is distinguished by the presence of other systemic symptoms like rash, kidney involvement, and distinct autoantibodies, e.g., ANA. 4. Polymyalgia rheumatica, PMR, involves joint pain and stiffness, particularly in older adults, and is typically seen in the shoulders and hips. It usually lacks the joint erosions of RA. 5. Acute inflammatory arthritis that can affect similar joints, but gout typically involves sudden severe pain with hyperuricemia and often affects the big toe or other lower limb joints. 6. Fibromyalgia causes widespread pain and tenderness, often confused with RA, but fibromyalgia lacks the inflammatory markers and joint swelling seen in RA. 7. Ankylosing spondylitis, AS, affects the spine and sacroiliac joints more than peripheral joints, but some symptoms, like morning stiffness, can overlap with RA. 8. Sarcoidosis can cause arthritis, but more commonly affects the lungs, lymph nodes, and skin. Joint involvement tends to be less aggressive than in RA. 9. Infectious arthritis. Conditions like viral arthritis, e.g., parvovirus B19, hepatitis B or C, Lyme disease, or septic arthritis can present with joint swelling and pain resembling RA. Number 10. Palindromic rheumatism. This intermittent inflammatory arthritis resembles RA, but is characterized by episodic flare-ups, and not all patients develop chronic RA. Accurate diagnosis of RA requires a combination of clinical evaluation, imaging studies, and laboratory tests, e.g., RF, anti-CCP antibodies, CRP, ESR. Several diseases can mistakenly fulfill the classification criteria for rheumatoid arthritis, RA, leading to misdiagnosis. This can occur because the American College of Rheumatology, ACR, European League Against Rheumatism, EULA classification criteria focus on joint involvement, serology, and inflammatory markers, which can overlap with other diseases. Some of these conditions include 1. Psoriatic arthritis, PSA. Overlap. PSA can involve small joints of the hands and feet, just like RA, and may be positive for rheumatoid factor, RF, or anti-CCP antibodies in rare cases. Differentiation. PSA typically involves skin and nail psoriasis, dactylitis, and enthesitis, which are not common in RA. 2. Systemic lupus erythematosus, SLE. Overlap. SLE can cause polyarthritis with symmetrical joint involvement, and some SLE patients may have positive RF or anti-CCP. SLE usually involves multi-organ systems, e.g. skin, kidneys, heart, and often has autoantibodies like anti-dsDNA or anti-Smith, which are not found in RA. 3. Sarcoidosis. Overlap. Sarcoid arthritis can present with symmetric polyarthritis that resembles RA, and inflammatory markers like ESR and CRP may be elevated. Differentiation. Sarcoidosis typically involves the lungs and lymph nodes and has characteristic non-caseating granulomas on biopsy. Viral arthritis, e.g. parvovirus B19, hepatitis B, C, chikungunya. Overlap. These viral infections can cause symmetrical joint pain, swelling, and elevated inflammatory markers that mimic RA. Differentiation. Viral arthritis often resolves spontaneously within weeks to months, and serological testing can identify the viral cause. Number 5. Ankylosing spondylitis, AS, and spondyloarthritis. Overlap. Peripheral joint involvement in AS and other spondyloarthritides can sometimes resemble RA, particularly in the early stages. Differentiation. AS primarily affects the axial skeleton, spine, and sacroiliac joints, and HLA-B27 positivity is common. Enthesitis and dactylitis are also more common than in RA. Number 6. Palindromic rheumatism. Overlap. This condition is characterized by intermittent episodes of arthritis, which can mimic early RA. Some patients with palindromic rheumatism have positive RF or anti-CCP antibodies. Differentiation. The episodes in palindromic rheumatism are self-limited and do not result in chronic joint damage or erosions. Now for 7. Gout. Overlap. Chronic gout can cause polyarthritis that mimics RA, especially if it involves the small joints of the hands. Differentiation. Gout is characterized by acute, painful attacks, often with tophi, crystal deposits, and elevated uric acid levels. Joint fluid analysis shows monosodium urate crystals. 8. Reactive arthritis. Overlap. Reactive arthritis can cause polyarthritis, often following infection, e.g., gastrointestinal or urogenital, and sometimes involves small joints similar to RA. Differentiation. Reactive arthritis is typically asymmetric and involves extra-articular features like conjunctivitis, urethritis, and enthesitis. 9. Polymyalgia rheumatica. Overlap. PMR can present with joint pain and stiffness, elevated inflammatory markers, CRP, ESR, and can fulfill RA criteria. Differentiation. PMR usually affects older adults and primarily involves the shoulder and hip girdles, without joint erosions typical of RA. Number 10. Primary Sjogren's syndrome. Overlap. Sjogren's syndrome can present with polyarthritis and may be positive for RF or anti-CCP antibodies, mimicking RA. Differentiation. Dry eyes and mouth, as well as specific antibodies, anti-Rho SSA, anti-LA SSB, help distinguish it from RA. 11. Fibromyalgia. Overlap. Patients with fibromyalgia often experience widespread joint pain and morning stiffness, which may be confused with RA. Fibromyalgia lacks the objective inflammatory findings, e.g., elevated CRP-ESR, synovitis, joint erosions, typical of RA. 12. Polymyositis, dermatomyositis. Overlap. These inflammatory myopathies can present with joint pain and stiffness, and inflammatory markers can be elevated. Differentiation. Muscle weakness, proximal distal, and characteristic skin findings in dermatomyositis are the key differentiators, along with elevated muscle enzymes, CK. Accurate diagnosis often requires a combination of clinical features, laboratory tests, and imaging studies to rule out these mimics and avoid misclassification of RA. Rheumatoid factor, RF, and anti-cyclic citrullonated peptide, anti-CCP antibodies, are both useful serological markers for diagnosing rheumatoid arthritis, RA. However, their specificity differs significantly, and understanding their role is essential for differentiating RA from other diseases. Rheumatoid factor, RF, is an antibody, commonly IgM, that targets the Fc portion of IgG, leading to immune complex formation. Although RF is commonly associated with RA, its specificity for RA is relatively low. Specificity of RF. Low specificity for RA. RF can be positive in many other conditions besides RA, which limits its usefulness as a highly specific diagnostic marker. These include other autoimmune diseases. Systemic lupus erythematosus, SLE, Sjogren's syndrome can be as high as 70 to 90%, systemic sclerosis, and mixed connective tissue disease, MCTD. Infections. Chronic infections like hepatitis C, up to 60 to 80%, tuberculosis, syphilis, and endocarditis. Other conditions, sarcoidosis, chronic liver disease, and certain malignancies. Elderly individuals, a small percentage of healthy elderly people, up to 10%, can have positive RF without any underlying disease. Sensitivity of RF, moderate sensitivity. RF is positive in about 70 to 80% of RA patients. However, in early RA, the rate can be lower, and it can take time for RF to appear. Conclusion for RF. High sensitivity but low specificity. RF is a useful marker for RA but lacks specificity, as it can be seen in many other diseases and even in healthy individuals, especially the elderly. Anti-cyclic citrullonated peptide, anti-CCP. Anti-CCP antibodies are directed against citrullonated proteins, which are found in the synovium of RA patients. Anti-CCP has become a more valuable diagnostic tool than RF because of its higher specificity. Specificity of anti-CCP. High specificity for RA. Anti-CCP antibodies are highly specific for RA, with specificity ranging from 90 to 98%. This makes it a more reliable marker than RF for distinguishing RA from other conditions. Other diseases. Anti-CCP antibodies are rarely positive in other conditions, but they can occasionally be seen in some other autoimmune diseases, e.g., psoriatic arthritis, systemic lupus erythematosus, or infections, though at much lower frequencies compared to RF. Sensitivity of anti-CCP. Moderate sensitivity. Anti-CCP is positive in about 60 to 80% of RA patients, comparable to RF. However, it tends to be positive earlier in the disease course and can predict more aggressive disease progression and joint damage. Conclusion for anti-CCP: high specificity and moderate sensitivity. Anti-CCP is a more specific marker for RA than RF and is particularly useful for differentiating RA from other diseases. It is also associated with disease severity and prognosis. RF versus anti-CCP. Comparative summary. Parameter: anti-CCP. Specificity for RA: low 70-85%, high 90-98%, sensitive moderate 70-80%, moderate 60-80%. Other conditions: positive in many diseases, SLE, Sjogren's infections, rarely positive in other diseases. Utility: useful but lacks specificity, highly specific, valuable in early RA. Conclusion: RF is helpful in RA diagnosis but has low specificity due to its presence in many autoimmune and infectious diseases. Anti-CCP is much more specific for RA and is the preferred marker for differentiating RA from other conditions, especially when there is diagnostic uncertainty. Testing both markers improves diagnostic accuracy, as double positivity, RF plus anti-CCP, is highly suggestive of RA. Ultrasound, US, plays a significant role in differentiating rheumatoid arthritis RA from other conditions that mimic its symptoms, particularly by helping visualize joint structures, synovitis, and inflammatory processes. It provides valuable insights beyond clinical examination and traditional imaging techniques, such as X-rays, by detecting early and subclinical changes. Here's how ultrasound helps distinguish RA from its mimics. 1. Detection of synovitis. Rheumatoid arthritis. In RA, ultrasound reveals synovial hypertrophy and active synovitis, inflammation of the synovial membrane, as early as the initial stages of the disease. Doppler ultrasound can detect active blood flow within the inflamed synovium, a hallmark of RA. Characteristic features: symmetrical synovitis in small joints of the hands, MCP, PIP joints, and wrists. Tenosynovitis, inflammation of the tendons, is common in RA and is well visualized on US. Power Doppler signals indicate active inflammation correlating with disease activity. Other mimics. Osteoarthritis. OA usually shows bony hypertrophy and osteophyte formation rather than synovial hypertrophy or significant Doppler signals. Synovitis in OA tends to be mild and localized to larger joints with little to no Doppler activity. Psoriatic arthritis may show asymmetrical synovitis and enthesitis, inflammation where tendons, ligaments attach to bone, which helps differentiate it from RA. Dactylitis, sausage digit, is also a key feature in PSA, visible as diffuse swelling on US. Lupus, SLE. Ultrasound may show mild synovitis, but often lacks Doppler activity, as SLE does not tend to cause the same level of joint erosions or aggressive inflammation as RA. Fibromyalgia. No synovitis or Doppler signal is seen in fibromyalgia, as it is a non-inflammatory condition. Pain in fibromyalgia is typically diffuse and tender point-based, with normal joint structures on ultrasound. 2. Assessment of joint effusion. Rheumatoid arthritis. Joint effusions, fluid accumulation in the joint space, in RA are typically seen alongside synovial thickening and Doppler signals, indicating active inflammatory arthritis. Other mimics. Gout can present with joint effusions, but ultrasound in gout typically reveals hyperechoic aggregates, urate crystals, within the synovium or joint fluid, described as a double contour sign. This finding is specific to gout and helps differentiate it from RA. Infectious septic arthritis may show large joint effusions, but synovial thickening tends to be less pronounced compared to RA. US-guided aspiration can help confirm infection by joint fluid analysis. Reactive arthritis. Joint effusions in reactive arthritis are often unilateral and occur in larger joints, e.g., knees, ankles. The inflammation is usually more localized and lacks the symmetrical pattern seen in RA. 3. Detection of bone erosions. Rheumatoid arthritis. Ultrasound is highly sensitive in detecting early bone erosions, especially in small joints, e.g., MCP and PIP joints. These erosions can be seen before they appear on X-rays and are a key feature of RA. Other mimics. Psoriatic arthritis. Erosions in PSA are often more irregular and asymmetrical, and there may be new bone formation in adjacent areas, unlike in RA, where erosions tend to be destructive without new bone formation. Osteoarthritis. Ultrasound in OA may show osteophytes, bony outgrowths, rather than erosions. The cartilage loss in OA is distinct from the synovial-driven erosion in RA. 4. Enthesitis. Rheumatoid arthritis. Enthesitis, inflammation at tendon ligament attachment sites, is not a primary feature of RA, though it can occur. The hallmark of RA is synovitis, primarily in the synovial joints. Other mimics, psoriatic arthritis, SA, and ankylosing spondylitis. Enthesitis is a prominent feature, often seen on ultrasound as thickening of the tendon or ligament at the insertion point, along with Doppler activity indicating inflammation. This helps differentiate PSA and AS from RA, where synovitis predominates. Reactive arthritis, enthesitis, particularly in the Achilles tendon or plantar fascia, can be detected on ultrasound and distinguishes reactive arthritis from RA. 5. Dactylitis, rheumatoid arthritis. RA does not typically present with dactylitis, diffuse swelling of an entire finger or toe, though tenosynovitis can cause localized swelling. Other mimics, psoriatic arthritis. Ultrasound can visualize dactylitis in PSA, showing swelling of both the joints and the flexor tendon sheaths. This feature helps differentiate PSA from RA. Reactive arthritis also shows dactylitis, but often in association with a preceding infection. Honor 6. Use of power Doppler ultrasound, rheumatoid arthritis. Power Doppler is essential for detecting active inflammation in RA, showing increased blood flow within the synovium, which correlates with disease activity. Other mimics. Systemic lupus erythematosus, SLE. Synovitis in SLE often lacks Doppler signals, which can help differentiate it from RA, where synovitis is more vascularized. Fibromyalgia. No Doppler signal or active synovitis is seen, helping distinguish it from RA. Summary of ultrasound features for differentiating RA from mimics. Feature rheumatoid arthritis, other mimic destructive erosions. Synovitis, symmetrical, small joints, Doppler asymmetrical in SA, mild, absent in fibromyalgia. Bone erosions, early destructive erosions, irregular in SA, osteophytes in OA. Enthesitis, rare, common in SA, AS, reactive arthritis. Dactylitis, uncommon, common in SA, reactive arthritis. Power Doppler strong, correlates with activity, weak in SLE, absent in fibromyalgia. Joint effusions, synovial thickening, Doppler signal, urate crystals in gout, large in septic arthritis. Conclusion. Ultrasound is an invaluable tool in distinguishing RA from other mimics due to its ability to detect synovitis, bone erosions, effusions, enthesitis, and Doppler activity. It provides real-time information on inflammatory activity and helps confirm or rule out RA when clinical features overlap with other diseases. Several child laboratory markers beyond rheumatoid factor, RF, and anti-CCP antibodies can help differentiate rheumatoid arthritis, RA, from other diseases that mimic its symptoms. These markers are useful for identifying other autoimmune diseases, infections, and metabolic conditions that present with joint pain and inflammation. Below are key markers and their role in differentiation. 1. Erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. Rheumatoid arthritis, both ESR and CRP are elevated in active RA, reflecting the systemic inflammation associated with the disease. Other mimics, systemic lupus erythematosus, SLE. ESR is often elevated, but CRP may remain normal or only slightly elevated in SLE unless there is infection or sericitis. This helps differentiate SLE from RA, where CRP elevation is common. Fibromyalgia. ESR and CRP are normal in fibromyalgia, distinguishing it from inflammatory conditions like RA. Osteoarthritis, OA. In primary OA, ESR and CRP are usually normal, except in cases of secondary inflammation. Gout. Both ESR and CRP can be elevated during acute gout flares, but these markers return to normal between attacks, whereas RA has more sustained elevations. 2. Anti-nuclear antibodies, ANA. Rheumatoid arthritis. ANA can be positive in a minority of RA patients, up to 30 to 40%, but high titers are uncommon. Other mimics. Systemic lupus erythematosus, SLE. ANA is almost always positive in SLE, 95 to 98%, and is a key marker for its diagnosis. High ANA titers, especially when associated with other specific autoantibodies, anti-dsDNA, anti-Smith, help differentiate SLE from RA. Sjogren's syndrome. ANA is positive in about 70% of patients with primary Sjogren's syndrome, often accompanied by anti-Rho SSA and anti-La SSB antibodies. Systemic sclerosis. ANA positivity is seen in most patients with specific patterns, e.g. centromere pattern, helping differentiate systemic sclerosis from RA. 3. Anti-double-stranded DNA, anti-dsDNA, and anti-Smith antibodies. Rheumatoid arthritis, rarely positive in RA. Other mimics, systemic lupus erythematosus, anti-dsDNA, and anti-Smith antibodies are specific to SLE and not found in RA. These markers are especially helpful when distinguishing SLE from RA in patients with joint symptoms. Drug-induced lupus. Antihistone antibodies may also be present, helping differentiate drug-induced lupus from RA. 4. Anti-Rho SSA and anti-LSSB antibodies. Rheumatoid arthritis. These antibodies are rarely positive in RA. Other mimics, Sjogren's syndrome, anti-Rho SSA and anti-La SSB antibodies are commonly positive in primary Sjogren's syndrome and can be present in SLE as well. Their presence along with sicca symptoms, dry eyes and mouth, distinguishes Sjogren's from RA. Systemic lupus erythematosus, SLE. Anti-Rho SSA and anti-La SSB can also be positive in SLE, often seen in subacute cutaneous lupus or neonatal lupus. HAT5, HLA-B27toid arthritis. HLA-B27 is not associated with RA. Other mimics, ankylosing spondylitis, AS, and spondyloarthropathies. HLA-B27 positivity is strongly associated with AS and other spondyloarthropathies, e.g. psoriatic arthritis, reactive arthritis. This marker helps differentiate these conditions from RA, especially when axial, spinal involvement is present. 6. Uric acid. Rheumatoid arthritis. Uric acid levels are not typically elevated in RA. Other mimics. Gout. Elevated serum uric acid levels are a hallmark of gout and help differentiate it from RA. Gout presents with monosodium urate crystals in synovial fluid, which confirms the diagnosis. It's important to note that normal uric acid levels during acute gout flares do not rule out gout. 7. Anti-neutrophil cytoplasmic antibodies. Rheumatoid arthritis. ANCA is not typically associated with RA. Other mimics, vasculitis, e.g. granulomatosis with polyangiitis, ANK, particularly CANCA, anti-PR3, and PANK, anti-MPO, are markers of vasculitides. These antibodies help distinguish vasculitis-associated arthritis from RA. 8. Synovial fluid analysis. Rheumatoid arthritis. Synovial fluid in RA typically shows a moderate to high white blood cell count, WBC, 5,000 to 50,000 cells, Michaelis, with predominantly neutrophils and a low glucose level. The presence of RF and anti-CCP antibodies in synovial fluid also supports RA. Other mimics. Gout. Synovial fluid analysis shows monosodium urate crystals under polarized light, which are needle-shaped and negatively birefringent. Pseudogout. Calcium pyrophosphate dihydrate, CPPD, crystals, which are rhomboid-shaped and positively birefringent, are seen in pseudogout. Septic arthritis. Synovial fluid in septic arthritis shows an extremely high WBC count, 50,000 cells microarray, predominantly neutrophils, and often positive culture for bacteria. Comp levels C3, C4. Rheumatoid arthritis, comp levels C3, C4 are usually null or slightly reduced in RA. Other mimics. Systemic lupus erythematosus, C3 and C4 levels are common in SLE due to immune complex deposition and complement consumption. This helps differentiate SLE from RA in patients with joint involvement. 10. Cryoglobulins, rheumatoid arthritis. Not typically associated with RA. Other mimics, vasculitis or hepatitis C-related arthritis. The presence of cryoglobulins, proteins that precipitate in cold temperatures, is associated with cryoglobulinemia, often linked to hepatitis C, and can help differentiate it from RA. Summary table of key laboratory markers. Rheumatoid arthritis. Differentiating other mimics, often linked to minority. ESR-CRP, elevated. Normal in fibromyalgia, mildly elevated in OA, high in gout. Positive in minority, 30 to 40%. Almost always positive in SLE, Sjogren's, systemic sclerosis. Anti-dsDNA, rarely positive, specific to SLE. Anti-Rho SSA, rarely positive. Sjogren's syndrome SLE, HLA-B27, not associated, positive in ankylosing spondylitis, psoriatic arthritis. Uric acid, normal, elevated in gout, negative, positive in vasculitis. Synovial fluid inflammatory 5,000 50,000 WBC, crystals in gout pseudogout, high WBC in septic arthritis. Complement C3C4, normal, slightly reduced, low in active SLE. Cryoglobulins negative, positive in cryoglobulinemia. Hepatitis C, vasculitis. Conclusion. A comprehensive laboratory evaluation, including specific autoantibodies, inflammatory markers, synovial fluid analysis, and complement levels, can significantly aid in distinguishing RA from its mimics. These markers, in combination with clinical findings and imaging, provide a more accurate diagnosis and guide appropriate management. Serum calprotectin and several other newer laboratory markers are emerging as potential tools in the diagnosis, differentiation, and monitoring of rheumatoid arthritis RA and its mimics. These markers may offer additional specificity or sensitivity in understanding disease activity, particularly in early or subclinical cases. Here's an overview of the role of serum calprotectin and other novel markers in RA and other conditions. 1. Serum calprotectin. Calprotectin is a protein derived from activated neutrophils and macrophages and is involved in the inflammatory process. It can be measured in both serum and synovial fluid and is gaining attention as a marker for RA and other inflammatory diseases. Role in RA. Marker of inflammation. Serum calprotectin levels are significantly elevated in patients with active RA and have been shown to correlate with disease activity. This correlation is often stronger than with traditional markers like CRP and ESR. Early detection. Calprotectin may be elevated in the early stages of RCA and is particularly useful for detecting subclinical inflammation, even when other markers are normal or mildly elevated. Prognostic value. Higher serum calprotectin levels have been associated with more severe disease progression and joint damage in RA patients. It may also predict relapses in patients in clinical remission. Monitoring response to therapy. Serum calprotectin decreases in response to effective RA treatments, e.g., DMARDs or biologics, making it a useful marker for tracking therapeutic response. Role in other mimics, spondyloarthropathies, e.g., psoriatic arthritis, ankylosing spondylitis. Calprotectin is also elevated in spondyloarthropathies, though its levels may be slightly lower than in RA. Elevated calprotectin in these conditions may correlate with enthesitis or dactylitis. Inflammatory bowel disease. Calprotectin, particularly in the feces, is widely used as a marker of gut inflammation in IBD. Serum calprotectin levels may also be elevated, especially in patients with associated enteropathic arthritis, gout and pseudogout. Calprotectin levels may rise during acute inflammatory flares of gout or pseudogout, but they tend to normalize between attacks, unlike in RA, where inflammation is chronic and sustained. Fibromyalgia. Since fibromyalgia is a non-inflammatory condition, serum calprotectin levels are normal, helping to differentiate it from inflammatory diseases like RA. 14-3,3-I proteins. 4-3-3 is a regulatory protein involved in signaling pathways that affect immune and inflammatory processes. Elevated serum levels of this protein are associated with joint inflammation and erosion. Role in RA. Diagnostic marker. 4-3,3-A is elevated in RA and has been shown to have good sensitivity and specificity, especially when used in combination with RF and anti-CCP antibodies. It may help in diagnosing RA, particularly in seronegative RA, where RF and anti-CCP are negative. Prediction of joint damage. Higher levels of 14-3,3 correlate with erosive disease in RA and may serve as a predictor of future joint destruction. Early RA. It is useful for detecting early disease and may be positive in patients with early stage or undiagnosed RA. Role in other mimics. Psoriatic arthritis. 14-3,3 levels may also be elevated in PSA, but generally at lower levels than in RA. This marker can help distinguish PSA from RA, particularly when used with other clinical and laboratory markers. Osteoarthritis. Levels of 14-3,3 tend to be low or normal in OA, helping differentiate it from RA. 3. Myeloid-related protein 814, MRP814 or S100AA9. MRP814, also known as calprotectin, but sometimes specifically measured as distinct proteins, is a complex involved in the inflammatory process and is produced by activated phagocytes. Role in RA. Inflammatory marker. MRP814 levels are elevated in RA and correlate strongly with disease activity. It is an early marker of inflammation, potentially helping detect preclinical RA or predict flare-ups in patients in remission. Prognostic value. Similar to serum calprotectin, high levels of MRP814 are associated with progressive joint damage and worse outcomes in RA. Role in other mimics. Other inflammatory diseases. MRP814 is elevated in spondyloarthropathies and systemic juvenile idiopathic arthritis, SJA, though its levels may not reach the same levels as seen in RA. Non-inflammatory conditions. MRP814 is typically normal in fibromyalgia and other non-inflammatory diseases. NASH4, anti-carbamylated protein, anti-CARP antibodies. Anti-CARP antibodies target carbamylated proteins, which are modified proteins found in the synovium of inflamed joints. Role in RA. Diagnostic utility. Anti-CARP antibodies are present in a subset of RA patients, particularly in those who are seronegative for RF and anti-CCP antibodies. They are an emerging tool for diagnosing seronegative RA. Prognostic marker. High levels of anti-CARP antibodies are associated with more severe joint damage and worse functional outcomes in RA. Role in other mimics. Other autoimmune diseases. While anti-CARP antibodies may be detected in other autoimmune conditions, they are much more strongly associated with RA and are less commonly found in diseases like SLE or SA. 5. Vascular endothelial growth factor, VEGF. VEGF is a growth factor that promotes angiogenesis, formation of new blood vessels, and is involved in tissue remodeling and inflammation. Role in RA, disease activity marker. VF levels are elevated in RA, particularly in active disease, and correlate with synovial inflammation and angiogenesis. It may help assess disease activity and monitor treatment response. Joint damage. Higher levels of VEGF are linked to more aggressive joint destruction, as VEGF contributes to the pathological changes in the synovium. Role in other mimics. Psoriatic arthritis. VEGF may also be elevated in PSA, as angiogenesis plays a role in both diseases. However, its levels in PSA are generally lower than in RA, making it less specific for PSA. 6. Soluble interleukin-2 receptor, SIL2R, is released by activated T cells and can be measured in the serum to assess immune activation. Role in RA, inflammatory marker. SIL2R levels are elevated in RA and reflect T cell activation, which plays a central role in the disease pathogenesis. It correlates with disease activity and can be used to monitor response to therapy. Role in other mimics. Systemic lupus erythematosus, SLE. SIL2R is also elevated in SLE, reflecting immune activation, but the patterns and clinical context differ from RA. Infections. SIL2R can be elevated in chronic infections, so it is less specific for RA than other markers. C1m and other cartilage degradation markers. C1m is a marker of collagen degradation and reflects cartilage turnover and destruction. Role in RA. Joint damage. C1m is elevated in RA and correlates with joint damage and erosive disease. It may help predict the progression of joint destruction and assess structural damage in RA. Role in other mimics. Osteoarthritis, OA. C1m levels may also be elevated in OA, reflecting cartilage breakdown. However, the combination of C1m with other inflammatory markers, e.g. CRP, calprotectin, helps distinguish between inflammatory RA and degenerative OA. Summary of new laboratory markers and their roles. Marker, role in RA, role in other mimics. Helps distinguish between calprotectin. Serum calprotectin correlates with inflammation and prognosis, elevated in spondyloarthropathies, normal in fibromyalgia. 14t33 protein, diagnostic and predictive of joint damage, mildly elevated in SA, low in OA. MRP814, S100A8A9, early inflammatory marker, joint damage, elevated in spondyloarthropathies, normal in non-inflammatory diseases. Anti-CARP antibodies, Associated with seronegative RA and severity? Rare. Several viral infections can present with joint pain, swelling, and inflammation, mimicking rheumatoid arthritis, RA. These viral arthritides typically cause acute or subacute joint symptoms that resemble early RA, but often resolve spontaneously once the infection is controlled. Differentiating viral Several viral infections can present with joint pain, swelling, and inflammation, mimicking rheumatoid arthritis, RA. These viral arthritides typically cause acute or subacute joint symptoms that resemble early RA, but often resolve spontaneously once the infection is controlled. Differentiating viral arthritis from RA is crucial because the treatment approaches differ, and unnecessary long-term immunosuppressive therapies can be avoided. Below are the key viral infections that can mimic RA, along with their specific clinical features and laboratory findings. 1. Parvovirus B19. Clinical presentation. Parvovirus B19 is a common cause of acute viral arthritis, especially in adults. Patients often present with symmetric polyarthritis, predominantly involving the small joints of the hands, wrists, and knees, similar to RA. The arthritis usually follows a febrile illness, and joint symptoms can persist for weeks or months. In children, parvovirus B19 infection causes erythema infectiosum, fifth disease, which manifests with a slapped cheek rash, but in adults, arthritis is the predominant symptom. Laboratory findings: RF and anti-CCP antibodies are negative. Parvovirus B19 IgM antibodies, or PCR, for viral DNA confirms the diagnosis. ESR and CRP may be mildly elevated, but systemic inflammatory markers are not as pronounced as in RA. Differentiating features. Unlike RA, parvovirus-induced arthritis is self-limiting and usually resolves within a few months. Absence of joint erosions on imaging also helps differentiate viral arthritis from RA. 2. Hepatitis C virus, HCV. Clinical presentation. Hepatitis C can cause chronic polyarthritis, which is often indistinguishable from RA in terms of joint involvement. Joint symptoms are usually symmetric, involving the small joints of the hands, wrists, and knees, mimicking RA. Extraarticular manifestations such as cryoglobulinemia, vasculitis, cutaneous vasculitis, and neuropathy are more common in HCV-related arthritis. Laboratory findings. RF can be positive in up to 70% of patients with HCV-related arthritis, complicating the differentiation from RA. However, anti-CCP antibodies are usually negative, which helps distinguish HCV-related arthritis from RA, where anti-CCP is more specific. Testing for HCV antibodies or HCV RNA is necessary to confirm the infection. Cryoglobulins may be detected in the blood, particularly if there is associated cryoglobulonemic vasculitis. Differentiating features. Anti-CCP negativity is a key factor in distinguishing HCV-related arthritis from RA. Joint symptoms in HCV-related arthritis may fluctuate with hepatic disease activity and tend to be less erosive than in RA. Treatment of the underlying HCV infection often leads to an improvement in arthritis symptoms, while RA requires long-term immunosuppressive therapy. 3. Human immunodeficiency virus, HIV. Clinical presentation. HIV infection can cause a variety of arthritic conditions, including HIV-associated arthritis, reactive arthritis, and even psoriatic arthritis. HIV-associated arthritis is often acute and self-limiting, but it can mimic early RA with symmetric joint involvement of the small joints. Other HIV-related conditions, such as reactive arthritis, Reiter's syndrome, present with asymmetric oligoarthritis, typically involving larger joints, often along with enthesitis and dactylitis. Laboratory findings. ORF is usually negative in HIV-associated arthritis, though false positive RF results can occur. Anti-CCP antibodies are typically negative. HIV antibodies or HIV RNA testing confirms the diagnosis. Synovial fluid analysis usually shows a nonspecific inflammatory response. Differentiating features: lack of erosions on imaging and the acute, self-limiting nature of HIV-associated arthritis help differentiate it from RA. HIV-related arthritis often presents alongside other systemic symptoms, such as fever, rash, and constitutional signs, which are not typical of RA. 4. Chikungunya virus. Clinical presentation. Chikungunya is a mosquito-borne viral illness that can cause severe polyarthritis or polyarthralgia. Joint involvement is usually symmetric, affecting the small joints of the hands, wrists, and ankles, similar to RA. Unlike most viral arthritides, chronic joint pain and arthritis can persist for months or even years after the acute infection, mimicking chronic inflammatory arthritis. Laboratory findings: RF and anti-CCP antibodies are negative. Diagnosis is confirmed by testing for chikungunya-specific IgM antibodies, or PCR, during the acute phase of infection. CRP and ESR may be elevated during the acute phase, but these markers do not persist in the chronic stage. Differentiating features: history of travel to endemic areas and the presence of fever and rash during the acute phase help differentiate chikungunya from RA. Imaging shows no erosive changes, even in chronic cases of chikungunya arthritis. Chikungunya arthritis often responds to NSAIDs and corticosteroids, while RA typically requires DMARDs for long-term control. 5. Clinical presentation. Rubella infection can lead to acute polyarthritis, particularly in adult women. The arthritis is symmetric and affects the small joints of the hands, wrists, and knees, closely resembling RA. Joint pain may precede or coincide with the characteristic rash of rubella, which typically begins on the face and spreads downward. Laboratory findings: RF and anti-CCP antibodies are negative. Rubella IgM antibodies, or PCR, confirm the diagnosis. Inflammatory markers like CRP and ESR are usually normal or only mildly elevated. Differentiating features: the rash and acute onset of symptoms help distinguish rubella-associated arthritis from RA. The arthritis in rubella is self-limiting, typically resolving within weeks to months without causing joint damage or requiring long-term treatment. 6. Epstein-Barr virus, EBV. Clinical presentation: EBV infection can cause polyarticular joint pain and swelling that mimics RA. It is often seen in the context of infectious mononucleosis, where joint symptoms may accompany fever, pharyngitis, and lymphadenopathy. Laboratory findings: RF can be falsely positive in EBV infection, complicating the diagnosis. Anti-CCP antibodies are usually negative. EBV-specific IgM antibodies, or PCR, can confirm recent EBV infection. Mononucleosis spot test may also be positive. Differentiating features: the presence of systemic symptoms such as fever, sore throat, and lymphadenopathy helps differentiate EBV infection from RA. EBV-associated arthritis is typically self-limiting and does not cause long-term joint damage. 7. Zika virus. Clinical presentation: Zika virus, another mosquito-borne illness, can cause acute onset polyarthritis or polyarthralgia that mimics RA. Joint symptoms are symmetric, involving the small joints of the hands, wrists, and ankles, often accompanied by a maculopapular rash, fever, and conjunctivitis. Laboratory findings: RF and anti-CCP antibodies are negative. Zika virus infection can be confirmed by PCR or Zika-specific IgM antibodies. Inflammatory markers are typically normal or mildly elevated. Differentiating features: the presence of conjunctivitis, rash, and fever differentiates Zika virus from RA. Zika-induced arthritis is generally self-limiting, with joint symptoms resolving within weeks. COVID-19, caused by the SARS-CoV-2 virus, has been shown to cause a range of musculoskeletal symptoms, including arthralgia, joint pain, and arthritis, which can mimic rheumatoid arthritis, RA. Post-COVID-19 inflammatory syndromes have further complicated this by presenting with persistent joint symptoms that may resemble autoimmune diseases. Here's an overview of how COVID-19 and its sequelae can mimic RA, along with key differentiating factors. 1. COVID-19 and acute arthritis. Clinical presentation. During acute COVID-19 infection, some patients develop arthralgia and, less commonly, true arthritis. Joint symptoms can range from mild joint pain to more severe polyarthritis. The arthritis can involve multiple joints and may be symmetric, affecting the small joints of the hands, wrists, and knees, patterns that resemble RA. COVID-19 related arthritis can occur in both the acute phase of infection and as a post-viral syndrome, sometimes persisting for weeks or months. COVID-19 patients can also experience myalgia, muscle pain, and fatigue, which can mimic symptoms of systemic inflammatory diseases like RA. Laboratory findings. RF and anti-CCP antibodies are usually negative in COVID-19 related arthritis, unlike RA, where these markers are often positive. Elevated markers of inflammation, such as CRP, ESR, and ferritin, are common in COVID-19, especially during severe infections, but these are nonspecific. Testing for SARS-CoV-2 via PCR or antibody testing confirms recent or past COVID-19 infection. Differentiating features. COVID-19 related arthritis is typically self-limiting and resolves over time, whereas RA tends to be chronic and progressive. The presence of other typical COVID-19 symptoms, such as fever, cough, shortness of breath, and loss of taste or smell, can help distinguish COVID-19 associated arthritis from RA. COVID-19 arthritis does not usually lead to joint erosions on imaging, unlike RA. 2. Post-COVID-19 syndrome, long COVID, and chronic arthritis. Clinical presentation. Many individuals who recover from acute COVID-19 infection go on to develop long COVID, a condition characterized by persistent symptoms lasting weeks to months. Musculoskeletal symptoms, including joint pain, stiffness, and swelling, are common features. These joint symptoms can resemble chronic inflammatory arthritis, and in some cases, patients may present with symmetric polyarthritis, similar to RA. Joint symptoms in long COVID may occur in conjunction with fatigue, brain fog, and muscle aches, which are also common in autoimmune diseases like RA. Laboratory findings. Similar to acute COVID-19, RF and anti-CCP antibodies are usually negative in patients with post-COVID arthritis. Inflammatory markers such as CRP and ESR may be mildly elevated, but are often less pronounced than in RA. Some patients with long COVID develop autoantibodies, but they may not be the same as those found in RA, e.g., anti-nuclear antibodies, ANA, or other nonspecific antibodies. Differentiating features. The history of COVID-19 infection and the presence of other long COVID symptoms, e.g., chronic fatigue, dyspnea, cognitive impairment, help differentiate long COVID arthritis from RA. Long COVID symptoms tend to fluctuate and may improve gradually over time, whereas untreated RA typically progresses and causes joint damage. Unlike RA, imaging studies in long COVID arthritis do not show joint erosions or synovial proliferation. 3. Reactive arthritis after COVID-19. Clinical presentation. Reactive arthritis is a post-infectious arthritis that can develop after various infections, including viral infections like COVID-19. COVID-19 has been reported to trigger reactive arthritis in some individuals, presenting with asymmetric oligoarthritis or polyarthritis affecting the lower limbs, knees, ankles, and feet, which can mimic RA. Reactive arthritis may also involve enthesitis, inflammation of tendons and ligaments, and dactylitis, swelling of an entire digit, features more typical of spondyloarthropathies, but can occasionally overlap with RA. Laboratory findings. RF and anti-CCP antibodies are negative in COVID-19 related reactive arthritis. Synovial fluid analysis typically shows a mild inflammatory response with negative cultures. Inflammatory markers, CRP-ESR, may be elevated, but less so than in RA. Differentiating features. Reactive arthritis is usually self-limiting and improves over time or with treatment, NSAIDs, corticosteroids, whereas RA requires long-term immunosuppressive therapy. A history of recent COVID-19 infection is a key clue in diagnosing reactive arthritis related to SARS-CoV-2. Reactive arthritis often involves lower limb joints more than the small joints of the hands, which are more characteristic of RA. COVID-19 and autoimmune disease triggers. In rare cases, COVID-19 has been linked to the new onset of autoimmune diseases, including RA-like arthritis. Patients may present with persistent symmetric polyarthritis after COVID-19 infection, which can fulfill classification criteria for RA. The exact mechanism by which COVID-19 triggers autoimmune diseases is not fully understood, but molecular mimicry, immune dysregulation, and cytokine storms during infection may play a role. Laboratory findings. Some patients may develop positive RF or anti-CCP antibodies after COVID-19, mimicking RA. Inflammatory markers such as CRP and ESR may remain elevated for extended periods. ANA or other autoantibodies can also be detected, suggesting an autoimmune process triggered by the virus. Differentiating features. COVID-19 induced autoimmunity might resemble RA, but the diagnosis is complicated by the fact that these autoimmune phenomena are often newly triggered by the infection. Time course and history of COVID-19 infection can provide context, but in some cases, it may be challenging to distinguish between post-COVID autoimmune arthritis and new-onset RA. Imaging studies may eventually reveal joint erosions in patients who develop true autoimmune arthritis following COVID-19, but this takes time. 5. Multisystem inflammatory syndrome in adults, MIS-A. Clinical presentation. MIS-A is a rare but severe inflammatory syndrome that can occur after COVID-19 infection, affecting multiple organ systems, including the joints. Patients with MIS-A may present with polyarthritis, along with fever, rash, cardiovascular involvement, and gastrointestinal symptoms. The arthritis seen in MIS-A is acute and may be mistaken for RA in the early stages, particularly if joint symptoms are prominent. Laboratory findings. RF and anti-CCP antibodies are typically negative in MIS-A. Inflammatory markers are significantly elevated, including CRP, ESR, ferritin, and D-dimer. Other laboratory findings may include lymphopenia, thrombocytopenia, and evidence of multi-organ involvement, e.g., elevated liver enzymes, myocardial damage markers. Differentiating features. The multi-system involvement and severity of MIS-A distinguish it from RA. MIS-A requires prompt recognition and treatment with immunomodulatory therapies, e.g., IVIG, corticosteroids, but it is generally self-limiting once treated, whereas RA is a chronic, progressive disease. Summary of